But thanks everybody for coming. I appreciate this. A great crowd. Thanks everybody for coming on a warm day. We'll be talking a little bit about dementia. And dementia is a broad category. We could talk for a week or more and not cover all the topics, but we'll hit the main points. We'll talk about some treatments, and then we'll go through some case studies about dementia. When we talk about dementia, we'll define what it is. By the way, there's two screens. We'll define dementia. We'll talk a little bit about the pathology, what happens in dementia. We'll go over some case studies which are supplied by the Mass General Hospital, who's done a lot of groundwork in dementia and dementia treatment. And then we'll go over the treatment itself. And can everybody hear me in the back? Am I projecting well enough? Okay. When we talk about dementia or memory disturbances, basically we're talking about the elderly with normal memory, normal recall, and a huge category called the worried well. These are people who walk into a room. Why did I come in this room? Yeah, that's normal, by the way. That's normal. Then we used to talk about mild cognitive impairment, but now we know that people with mild cognitive impairment are really on their way to having dementia, to having a full-blown dementia. So what exactly is dementia? We said we were going to define it. Well, medically, dementia is an impairment in short and long-term memory, especially short-term memory. People will say, wives will usually tell me, well, he knows what he did in 1970, but he doesn't remember what happened last week. So long-term memory is relatively preserved. Problems with short-term memory, however. And then at least one of the following: aphasia, difficulty with language. Apraxia is just a fancy term of saying somebody can't do what they could previously do. And then agnosia, not knowing what's going on. You know, there's a lot of things to worry about in neurology. There's terrible stroke syndromes, brain tumors, horrible prion diseases that people can get. In a lot of ways, though, dementia is not one of them that should be worried about, because when you get it, because of the agnosia, you're not going to know it. And by and large, you're not going to know you have a dementing illness. So thank goodness maybe the Creator gave us that loss of insight. And then there's impaired abstract thinking. You know, there's concrete thinking when you ask somebody, well, what is voting? Well, voting, you go into an empty school and then you pull a lever, and as opposed to an abstract thinker would say, voting, well, that's the bedrock of our democracy. That's what we... So abstract thinking is impaired in dementia. Impaired judgment, personality change, but these disturbances all have to interfere with their work or social activities. If somebody's hanging around the house all day, they begin to get memory disturbance, have these symptoms, but it's not interfering with their work or social activities. It's not really dementia. And also, to qualify as dementia, there has to be an absence of delirium. What's delirium? Many of you know that people who go in the hospital, they get a bladder infection. They can go bonkers. They can't remember things. They start acting kind of in a goofy manner. That's delirium. That's temporary. That's not dementia. What conditions can cause dementia? There are many of them. Degenerative brain diseases such as Alzheimer's is what we'll be talking about. By the way, Alzheimer's is the largest category of dementia. Alzheimer's disease is a type of dementia. Strokes, brain tumors, infections, particularly the bladder infections that we talked about, thyroid problems, adrenal gland problems, sleep disturbances. Those are major and can put people at risk for memory disturbance and even outright dementia. Trauma, head trauma. World War II veterans who had head trauma and then went on to get dementia, they were twice as likely to have dementia as veterans their same age who did not have head trauma. So head trauma is a risk factor for dementia. Depression, especially in midlife, is a major risk factor for dementia. So Lots of times in medicine, doctors are too aggressive to prescribe pills, you know, a pill for every ill, and before you know it, by the time you're 65, you got 10 or 15 pills you're taking. But in order to combat dementia and the risk factors for dementia, we're pretty aggressive in treating sleep and depression, because we know that down the road they can set the stage for dementia in an elderly state. High blood pressure, that's a major. High blood pressure in a middle-aged man with sleep disturbance and depression, watch out, that's really setting the stage for dementia down the road, and that can of course be prevented by and large. Now, when you go to the doctor, what we'll do to work up a patient that we think might have dementia, of course we'll do a history, we'll ask some brief questions about the mental state, a physical exam, which is usually normal in dementia. There's some blood tests, mainly thyroid, bladder function test, adrenal test, and then we'll do a brain scan sometimes, like a CAT scan or an MRI, to make sure there's not a tumor or what have you. And then a mental status exam, which is a little bit more in-depth of a memory test that we do. Now, we talked about those neurodegenerative diseases. That was one of those 9 things that can cause dementia. Here's what they are. By far and away, Alzheimer's makes up the majority of dementing illnesses. But there's also post-stroke state. Strokes can cause dementia. We'll have some slides about that. Lewy body disease, which is a real interesting disease that combines Alzheimer's and Parkinson's in Lewy body disease. And then there's things like hydrocephalus, prion diseases, some of the other rare dementias that we'll also have some cases we'll talk about. Here's who started it all. This is Dr. Alzheimer. He was a neurologist in Frankfurt, Germany over 100 years ago. He became friends with a patient named Augusta D. She was only 51 years old. And as was the custom back then, he befriended her, became her physician, and then when she died, he performed her autopsy. We'll go over some of the findings that he found. So we went over some of the diagnostic criteria for dementia. The ones for Alzheimer's disease are really exactly the same, except there's impairment in what's called executive function. Those involve the frontal lobes of the brain, and it has to do with planning, performing multitasks, going ahead and doing things in a sequential fashion. Those are all impaired in Alzheimer's disease, and there is progression over time. Gradual onset, especially in short-term memory, and progressive decline. And once again, it has to interfere with daily activities, otherwise it's not dementia, because it's not going to cause a problem. Some of the clinical features of Alzheimer's disease, what doctors like to do, tap your reflexes, check your muscle strength, check your sensation, especially neurologists like to do that. All that's normal in Alzheimer's disease in a demented patient. By and large, it's normal. What's not normal are some of the more subtle psychiatric changes that take place, like that executive function we talked about, personality change, apraxia. We talked about that already. You can no longer do what you could previously do, a learned task. Here's a case study. This is an 81-year-old chiropractor, GC. 2003, gradual onset of remembering where he placed things. The next year, he was unable to organize his financial data, which he could usually do quite well. A couple of years later, he came to neurologic attention. He was frustrated with his memory, but he still worked several days out of the week. His language was intact, orientation, reasoning, all that was intact. He was independent in his ADLs, activities of daily living, toileting, preparing meals, driving. He could do all that. May of 2006, his exam was still normal. June of 2006, his MMSE, some of you may have had an MMSE. It's a mini mental status examination. We ask a series of questions. A normal score is 30 out of 30. If you're less than 24, you can qualify as being demented given the certain circumstances. Anyway, he scored 24 out of 30 3 years into his illness, so he's doing fairly well. He was checking out at the checkout nurse's station. He died of a heart attack, had a heart attack right there. Actually, I'm jumping ahead. Before he died, his delayed recall was just a tad off, 5 out of 10, whereas an age-matched normal person would be 6 out of 10, so just a tad off. That's the only thing that was really found wrong. Everything else was normal. He died checking out one day at the nurse's station in 2006. This is what his brain showed. Remember, his memory was just a tad off. This is the same thing Dr. Alzheimer found when he did the autopsy on Augusta D. These little plaques outside of the neurons. The neurons are the nerve cells, the gray matter, the actual workhorses of the brain. It's the outer 1/4 inch of the brain. Anyway, outside of these neurons are these plaques, which are accumulation of protein. They interfere with communication between the neurons, the nerve cells. He also was found to have tangles inside the neurons. Tangles involve the tubules that the neuron uses to transport nutrients within the nerve cell. They get tangled up and mixed up and no longer function in Alzheimer's disease. So plaques outside neurons, tangles inside neurons. That's what Dr. Alzheimer originally found over 100 years ago. This is the brain of the chiropractor that we talked about. You can see, so it's a little difficult to see. Here's the occipital lobe, the back part of the brain, responsible mainly for vision. Very well preserved, tight and compact. When you move into the frontal lobes and even the temporal lobe here, we talked about the frontal lobes for executive planning, executive tasks. You can see the atrophy that's taking place. So relative preservation in the back part of the brain, atrophy starting in the middle part and front part of the brain. Those are the gross findings that we see. We already looked at the microscopic findings in Alzheimer's disease. This is the gross finding in some of those cases, brain atrophy. Here's another case, HR, born in 1925, died 2005. 1997, some subtle word finding difficulty, just some subtle findings with language, some problems with that. 3 years later, neurologic exam showed problems with speaking. Couldn't really name objects very well. A car, something you travel in. Looking at a picture of a car, couldn't say the word. MMSE score was really normal. We talked about 24 out of 30 or less might be abnormal. She's normal. 2002, 5 years into the illness, just a little bit down, 22 out of 30. Sings better than she speaks. Worsening language. 2003, more aphasia, language problems, withdrawn personality. MMSE continues to decline a little bit, but not so much as you would expect. In 2004, she was mute, but still could perform her personal hygiene. This is what her brain looked like. You remember the last one showed relative preservation of the back part of the brain. Same thing here, it's beautiful. But now there's even more striking atrophy than that first slide we looked at, especially in the mid part, the frontal part, mid part, and then along the temporal lobe. It's fairly severe atrophy taking place. This is a situation of what's called Pick's disease. Pick's disease is a rare type of dementia. It's not Alzheimer's disease. Some of you may have heard it called frontotemporal dementia. Some families have frontotemporal dementia in their gene pool. But she had a case of Pick's disease. It presents with dementia, slow, steady deterioration, and then relative preservation of memory and parietal lobe functions. That's why her MMSE score didn't really drop off that much, even as she was in the process of dying. But her language and personality were affected. At the Mass General Hospital of dementia cases that went to autopsy, far and away Alzheimer's disease is the main. Only 3% were Pick's disease. Personality, language impaired in Pick's disease, not as much memory. There's none of those plaques or tangles that we looked at earlier that Dr. Alzheimer saw. They're these things, Pick bodies, which are accumulation of protein within the nerve cell. So that's Pick's disease, also known as frontotemporal dementia. It's another type of dementia. So all dementia is not Alzheimer's. Here's another situation. This patient in 1989 began to have difficulty arising from a chair, hypophonia, a weak voice, difficult to produce speech, postural instability. These people tend to fall backwards, and if you come up behind them and just tap on their shoulders and pull back, they'll fall back almost immediately. They tend to get hip fractures, as he did. Difficulty focusing, especially looking down. These people simply cannot look down. It's difficult for them to look up, but they cannot look down. So as you might imagine, they fall down the stairs. Parkinsonism, meaning he was just kind of rigid in his muscles, more rigidity. 2003, his eyes were fixed, he fell, had a skull fracture. Here's a PET scan. A lot of people like to talk about PET scans. They want PET scans. PET scans are pretty good sometimes. They're probably more used in cancer medicine, but sometimes they come in handy in neurology. They're very expensive and hard to get paid for in neurology. This is a normal PET scan of the brain up top. This is the patient's PET scan on the bottom. You can see these red areas. Here's the frontal lobes, red areas. Those are areas of uptake of glucose. Glucose is being used in the brain. That's good. The redder, the better in this circumstance. You can see that there's a striking difference between the two. Right here, this is appropriate, normal. Down on the bottom, there's simply not enough glucose uptake. This patient had progressive supranuclear palsy. Some of you remember Dudley Moore. You remember the actor Dudley Moore? Well, you know, he got involved in that altercation years before he died at Barbra Streisand's house, and it was said he was drunk and disorderly and stumbling about. But ended up, he had PSP. He eventually died from PSP. It's a progressive supranuclear palsy, gradual progressive disorder, onset after age 40. Ocular palsy, these people simply cannot look down, so falls, slow eye movements, and postural instability like we talked about. They fall backwards, they break a hip, fracture a skull. It's a terrible disease, PSP. Here's another case study. This is AL. He's a physician, born in 1926. 1999, he was diagnosed with Parkinson's disease. Started Sinemet, which is our go-to medicine for Parkinson's disease. A year later, he had some mild memory loss. He left on vacation, forgot to tell his colleagues. A couple of years later, got lost. 2003, hallucination, dogs and children in the living room. If you ever meet a family member of a person who has this and you ask them, has he or she seen any dogs or little children? They can't believe it. They think you've talked with them on the phone before they came. But that's characteristic, dogs and children hallucinations. By 2004, had worsening Parkinson's disease. His MMSE was 12 out of 30. We talked about you want to be 24 out of 30 at least. 2005, worsening dementia, hallucinations. And then in 2006, he died of a pneumonia, which is a usual cause of death in a person with dementia, pneumonia. This is what his brain looked like. These are neurons. These are protein buildup inside the neurons. Those are called Lewy bodies. Those are just protein accumulations that occur in this disease, which is called Lewy body dementia. It's a combination of Parkinson's and dementia. Hallucinations. These people get very sensitive to Neuroleptics, that's just antipsychotic medicines. That's like Haldol. If somebody with Lewy body disease goes in the hospital and starts acting strange and they get Haldol, they'll get stiff as a board and they'll die of a pneumonia. So that's neuroleptic sensitivity in Lewy body dementia. In comparison with Parkinson's disease, Lewy body has increased muscle twitching, decreased resting tremor. Y'all know about the resting tremor in Parkinson's, kind of a pill rolling tremor that goes away when somebody starts to use their hand and their arm. It's more of a rest tremor in Parkinson's disease. Decreased response to Sinemet in Lewy body disease and a later age of onset. So Lewy body dementia, it's another type of dementia, Parkinson's combined with Alzheimer's. Here's another case, just finishing up. This is a retired teacher, 2006, slow walking and difficulty balance, was diagnosed with Parkinson's. Sinemet, that's our gold standard for treating Parkinson's. December of 2006, was confused, so it must be the Sinemet, so the Sinemet was stopped. However, continued to progress, worsening mental state, in a wheelchair, urinary incontinence. This is his CAT scan. You know, the ventricles are cavities in the brain that help cushion the brain and help provide nutrients to the brain cells. His ventricles are huge. They should be smaller than this. Here's the ventricle. You can see where it might put pressure on the frontal lobes. Many of you already know this is normal pressure hydrocephalus. This is not him, this is another pathology specimen. Huge ventricles in the brain. They could put pressure on the outer cortex of the brain. Here's the cortex. By the way, this person had a stroke in the temporal lobe on both sides. So, back to this same patient, he underwent a high volume spinal tap. You have about 120 cc's of spinal fluid in your body at a time. The doctor took off a third of that. Before the lumbar puncture, it took him 40 seconds to walk 20 meters. After the lumbar puncture, it took him 20 seconds. His thinking was improved, and usually it's a eureka response. When people get up off the table, they know right away they're doing better, and especially their spouse does. 2 months later, he underwent a VP shunt, which is like having a permanent lumbar puncture. A tube goes in the ventricle of the brain, tracks down the neck, and then goes in the stomach to take away that excess fluid continuously. His MMSE, you know, we talked about that. You want to be over 24. His before the shunt, 12 out of 30. 2 weeks later, after the shunt, 19 out of 30. A year later, it had normalized, 30 out of 30. Walking well, no bladder incontinence, so you return to work. So that's an example of a reversible dementia. Not all dementias are untreatable, nothing to do about them. Normal pressure hydrocephalus is a reversible dementia. Just another case here. 1934, this patient was born. 2005, right upper extremity weakness, and then transient aphasia, difficulty with language. 4 years later, left leg weakness, and then neglect of the left side of his body. A year later, his memory, worsening mental state, and then he suddenly developed left hemiparesis, left-sided weakness in the whole body. Here's his CAT scan. This is difficult to see. This is a CAT scan. Some of you can make out right around the outer part of the brain, the cortex, there are a number of strokes that have taken place. So he's had 7 or 8 strokes over the years. This is what's called multi-infarct dementia. So that's a dementia caused from vascular disease, caused from strokes. It's what they call a stepwise progression, whereas Alzheimer's disease is just slowly, steadily worsening. In multi-infarct dementia, these people do okay, then they'll get worse. Then they'll get worse. So those are, as the strokes occur, stepwise progression, multi-infarct dementia due to strokes. Now, if somebody has dementia, there are a lot of non-pharmacologic interventions that can take place. A stable environment. People say, boy, we go on vacation, Daddy went bonkers. Well, people don't do well when they change environments. I've got one family, Daddy spends a night here with one son, a night here with the daughter, and so several times a week Daddy's moving, and so he doesn't know what's going on. These demented patients need a stable environment. They need consistency. Therapeutic fiblets. It's not good to lie. We've all been taught not to lie, but here's what happens with demented patients. I've had it happen in the office. I can't tell you how many times. Daughter comes in with mom. I ask mom where she is. She'll say, Bishopville or Santee. What's the daughter say? Mama, I told you we're in Clemson. How many times have I told you that? What's today? Wednesday. Mama, it's Monday. So the daughter jumps right in there, correcting her. Mom gets agitated, gets upset. That doesn't do anybody any good. So when you got a demented patient, Mama thinks it's Wednesday. That's right, Mama. That's right. Or Mama, I want to go home. I want to go home. I want to go home. Mama, you can go home as soon as we eat supper. Let's eat supper. Because in a few minutes, unfortunately, Mom's going to forget about that anyway. But if you say, no, Mama, you're home, she's going to get upset. You'll get upset. So therapeutic fiblets really come in handy. And then, when you visit a nursing home, the patient's glasses are maybe in a drawer, the hearing aids are at the nurse's station, the dentures are in a glass by the bed. So the patients really need access to all those things. They need to be able to see and hear. They need to have that input coming in. Nutrition, exercise, plenty of water intake. Sleep is major. We talked about that in middle life. The middle-aged people need to be getting at least 7 hours. If not, they need to look into that. Emotional support, spiritual support. People who go to a religious service have less dementia, and the dementia they have is less aggressive. Some of you have seen the light and sound therapy, where they have pleasing sounds like a train whistle. Reminiscence therapy, where they get a bunch of demented patients together and they talk about things that happened in the 60s, the 70s, the 50s. And promoting those long-term memories can help short-term memory recall. So there are a lot of non-pharmacologic things we can do. Pharmacologic things, just finishing up, cholinesterase inhibitors, things like Exelon, who has the patch now, Aricept, Axona, which is a nutritional food for dementia, Namenda, then antidepressants and antipsychotics. Demented patients tend to sundown. Sunlight is stimulatory and it helps us organize our thoughts. When that sunlight begins to dwindle, people do worse. They can start to see things, hear things, get agitated. That's where a low dose of an antipsychotic can really help. Dementia is associated with depression. That's something we can treat. So all these medicines are used to help with dementia. Cholinesterase inhibitors, that's just a fancy word for saying it builds up acetylcholine in the brain. In Alzheimer's disease and all types of dementia, the cells in the brainstem that make acetylcholine are destroyed. So that reduction in acetylcholine correlates well with the severity of dementia. So we give medicine to increase acetylcholine in the brain. There's really three that we use. There's Rimonil, Aricept, and Exelon. Exelon has an oral and a patch, as you know. Now here's just briefly, this slide is about Aricept, but really it works for all of them. Here's a patient on placebo, just on a sugar pill. Over 24 weeks, their decline in their daily activity scale. Regular Alzheimer's patient declines fairly precipitously. 5 milligrams of Aricept, 10 milligrams of Aricept a day helps to stabilize that decline and keep them at a higher level of function. It's not going to cure dementia, but it can give people time to make their advanced directives, prepare a living will, spend time with their family, go on a trip, all those things they wanted to do. It can stabilize people for sometimes up to a year. Because it works on acetylcholine, the main side effects are gut related, because our gut, our stomach and our intestine use acetylcholine for digestion. So if you stimulate acetylcholine, you can get diarrhea, nausea. Usually after 6 to 7 weeks that goes away. Now Namenda is another one that we use for dementia. Namenda decreases levels of glutamate. Glutamate is a neurotransmitter that's associated with damage to neurons. Glutamate is inhibited some by Namenda. Same type thing we've seen. This is a severe impairment battery. So these patients had severe Alzheimer's, declined steadily over time. This is a 28-week study. That decline was delayed a little bit and weakened somewhat by the Namenda. That's just more about the severe impairment battery. Here's another study, same type of thing, over 28 weeks, preservation of function with Namenda. Now this is a healthy brain. This is another type of functional scan, like a PET scan. We talked about the red areas. Red is good. Red involves glucose metabolism. Here's an Alzheimer's patient. Not as much red, so they don't utilize glucose as well as they should in the brain. That's why Axona was developed. Axona is a nutritional food that people take that uses fats and ketones for brain function as opposed to glucose. It's used twice a day. Similar, here's cognitive function. These patients are on Axona nutritional food, some improvement, whereas the regular Alzheimer's patients on placebo tend to decline. This is a washed out area where they were both stopped, and you can see a decline. Well, thank you very much for your attention. I'll be glad to answer any questions. Thank you. Thank you.